Good afternoon, Dr. Manjula, once again, and warm welcome to all the panelists over here. Dr. Shubhalakshmi, I think you will like to moderate the session, and I can be on behalf of Dr. Anupam if he joins. Nothing like that. Otherwise, I will take the questions.
Yeah.
Yes, sir, sure. And thank you, ma'am, for this invitation and this opportunity for this wonderful panel. So we have been learning about fever, typical and atypical, various type of fever with different causes since 2 days in this FEFCON. And just now also we have heard about just wonderful panel discussion on ICU, fever in ICU. So moving on to our next session, this session, as madam said, non-localizing fever. Do I give an antibiotic? This is the topic for this panel discussion. And we have expert with us, as ma'am already introduced, Dr. Ashutosh Biswas, Dr. Jayant K Panda, Dr. Ramesh Agarwal, and Dr. Anupam sir if he joins. So ma'am, we can have the slides.
Yeah, I will share, ma'am.
Yeah. So various fevers we have just seen in 2 days. Non-localizing fever, what we understand, what we have to learn about, or how we have to go about it. This will be discussed in our panel, and our expert will be telling us about this. So first question, can we have the slide? So first question I would like to ask to Dr. Ashutosh Biswas sir. Sir, would you please tell us what does one understand by this non-localizing fever, or how does one define this non-localizing fever?
The Fever Foundation, I would like to thank the organizers, especially Dr. for giving the opportunity in the very special panel discussions. So to begin with that, it's very important topic that localization of the fever of antibiotic. This is a very important thing. Most of the time, what we think that fever causes, as we know, causes of fever mostly due to infectious and non-infectious cause. Now, in between the prescription by the doctors and using the antibiotic and then localization, what is the importance of it? Localization, and why you want to look for localizing the fever, and what are the approaches to localize, and how does it help in prescribing the antibiotic? So most of the time, can you really localize the fever when somebody is coming with the fever? Is it possible that we can really localize and to know before prescribing any antibiotic? So how to approach this localization of fever? Basically, we understand the clinical approach, and then if not, we fail to localize it, then we go for the laboratory investigations. There are various ways to know: lab, molecular diagnostic, or maybe histopath, or several other diagnostic procedures we follow to localize, and then finally also most of the time we go for imaging. So basically these are the three ways we approach. Now this most of the time the use of antibiotic, burden of use of antibiotic is by clinical acumen. Most of the time we try to misuse the antibiotic. Our habit, prescription habit, or the behavior of the physicians, mostly at this moment we have discussed over these 2 days, is really we are abusing the antibiotic, and we see the now emerging of resistance of the antibiotics. So the rational use has already been discussed in this forum for last 2 days in antibiotic seminar and all. So we have to really how to change our behavior. So not only the physician's behavior, is the behavior of the society, is the behavior of the pharmacy, that where you are getting this antibiotic. So how to curtail, how to curb this habit and the use of antibiotic, that's the most important thing. Now, among the doctors, when somebody is coming with the fever, so localization is a very important. That is the hospital setting, or maybe as an OPD setting, than sometimes in the clinic. So that we have to understand. So how really, if somebody is coming with a fever. Now it is time consuming to localize by laboratory investigation and imaging technique, getting an X-ray done and the ultrasound done and CT scan done and something. So by the time you get this all investigations to confirm, you get the evidence, many 2-3 days or maybe more than that you already pass. So can you stop using antibiotic, and what are the really challenges that we face? So clinical localization is a very important thing when somebody is coming with a fever something. So we try to localize with the respiratory tract infection. So whether along with the respiratory tract infection, if it is a respiratory tract infection, so what are the other symptoms and signs? So those are the very important to localize really. So there are other organs that we know is, so we try to localize that by the symptoms and signs. So we have to particularly have a patience to understand the organ involvement and the tissue, because the various organisms, they have their different nature of damaging involving the tissues. So fever is what is really the immune response, the immunological response through the metabolic cellular activity, and this is that we get the fever maybe through the inflammatory process of infectious cause or non-infectious cause. So it's not that fever is the antibiotic we're going to use, and there are all we know that fungus there and viral there, and antibiotic particularly is for against the bacterial infection. So that is the most important thing. So if we want to localize somewhere the bacterial infection to use for getting a scope or a window for using the antibiotic. So what percentage of that patient with coming fever that we could really localize it? If we fail, so can you use as a empirical therapy? So basically point is we should try, definitely there is a route of entry of all the organisms to cause to enter in your body. So through the route, naturally there is a route of entry, and this organism try to cause the nuisance at the root, and then probably if it is spreading throughout the body, then can cause a systemic, and you may not really catch it that there is a local infection, local cellulitis or local inflammatory process going on. So that is what the sign of localization of the fever.
Okay, sir.
And
Yeah, sir.
Sir,
we will be coming back with
sir,
we will be coming back with other questions, because
okay,
I think
sure.
we have, yeah, sir. Thank you very much, sir.
Okay.
So what sir has told, that if we have no signs of localization, if we in a patient, if we are not getting any sign or clinical symptom or even after investigation, then we call it as a non-localizing fever. So now moving on to the next question, we have with us Dr. Jayant Panda, sir. He is Professor and Head Department of Medicine of SCB Medical College, Cuttack. Welcome you, sir. And for you, we have question. Can we have the next slide, please? So, sir, what are the different or common causes of non-localizing fever, and do they have or do they vary from region to region, different region to region?
Yeah, very pertinent question, Shivalakshmi. The commonest cause that we get fever in our locality, which are tropical areas, depends on the environmental situation. As we already know, in the hot summer, anybody coming with fever will think of heat stroke. We don't think of an infection. And in a lady with a different polyarthralgia, if it comes, we think of a immunological cause like rheumatoid arthritis, like lupus, like progressive systemic sclerosis. In an elderly patient who comes with a continued fever, we think of a malignancy sitting somewhere. In a young person with a very high leukocyte and without any localization, can be a patient of adult onset Still's disease. So there are so many varied regions, starting from malignancies to immunological causes. I have seen hundreds of patients with a metabolic cause like hyperthyroid state presenting with POO, and we have worked out with a thyroid function test and knew the cause of fever, and they have received tons of antibiotic in the peripheral hospital with a different consultant who have never cared to diagnose the patient. So depending on the locality, depending on the age of the patient, depending on the environmental condition, these cause of fever are different. And when we approach a patient, we have to remember that this patient can have a cause which may not be infection altogether. So in this context, my argument will be in a patient who is not having a localizing cause, we should not jump to an antibiotic immediately. That's what is contributing towards the antibiotic resistance. And then even a quack, even a medicine shopkeeper is daring to start antibiotic. And you know, during COVID time, how many people started with azithromycin and the symptomatic medicines around. So we can diagnose non-localizing fevers depending on their presentation, age group, environmental locality, and the investigation should should include the panel, including the immunological panel, including the metabolic panel, including the panel to rule out the other causes like a malignancy or like a environmental condition. So it's not all about infection. As Dr. Ashutosh Biswas has told, we have to think of an immunological response which is causing fever. So jumping to antibiotic doesn't help. That's a practitioner approach. Anybody comes giving an antibiotic, giving a PPI, giving an antibiotic, I'm not in favor of that. Rather, you should take a careful history, investigate the different related panels, and once you get some clue, maybe you have a leukocytosis, maybe you have a respiratory shines in the form of bronchial breath sound, crepitations, maybe if you have a skin and soft tissue lesion with pus coming out, there you can send a culture sensitivity and plan antibiotic.
Yes, sir. Thank you. Thank you very much, sir. For investigation, we will be moving on to the next question. But yes, as you said, antibiotic should not be the choice without thinking about the cause or without getting the cause. And very rightly said that region, the cause may or it varies from region to region. Like you said, in heat stroke, where it is very hot and humid, we should think of this cause first. And if any fungal infection, if in urban or rural areas where the patient is coming from, we have to think about that also. So now moving on to the next question, we have with us Dr. Yeah. So moving on to next question, we have with us Dr. Ramesh Agarwal, sir. He is Professor of Medicine from Lady Hardinge Medical College. Welcome you, sir. And question for you, or I would like to know, how can we diagnose these non-localizing fevers, and what investigation one should do, and when we should be doing these investigations?
Thank you, Dr. Shivalakshmi. Dr. Shivalakshmi, already Dr. Ashutosh and Dr. Panda sir has told that fever is not entirely about infections. It is both infectious and non-infectious etiology what we have to look at. Particularly for the non-infectious as the autoimmune diseases, the malignancies, and of course the drugs which can cause fever, which do not respond to your usual treatment. So one thing I would like to say is that already we are in a soup, like we are not able to clinically diagnose a patient, and we should not take an approach which again will which will land us in some more trouble. Like the approach should be somewhat a step ladder type of a approach, that we should go from below upwards rather than jumping from the roof and again landing nowhere. So for this, like basic investigations, a hemogram and LFT, KFT should be ordered first. And that's the key message which we would like to give from this platform to our residents and to the august audience which are here. Like a simple hemogram can give you a vital clue. For example, if a patient comes to us with a TLC of 13,000, so maybe an immature physician may ignore it or say that it might be somewhat a little infection and start antibiotics at one go, as Dr. Panda was saying. But looking at more say carefully or the DLC, it may show you a majority of the lymphocytes which are there and not neutrophils. So where does the role of antibiotics come there, which has got a 60% of lymphocytosis in a, say, a TLC of 13,000 to 15,000? That should make you more suspicious of some other causes, maybe some malignancy which is going on or some autoimmune disorder which is going on. Of course, there can be variation between lymphocytosis and lymphopenia. Similarly, investigation in hemogram of an eosinophil, so that may give you vital clue whether there is some parasitic infection or some sort of say a vasculitis or a lymphoma which is there, or presence of abnormal cells. So the message here is a careful hemogram with the peripheral smear should be the first approach when we are hunting for something which we do not know. Then, of course, ESR and CRP are there. They are non-specific, but if we really see that very high levels of ESR, they still are relevant for diagnosing tuberculosis. So they give you more information that probably this patient is having some chronic systemic disease, maybe in the form of a tuberculosis or some underlying brucellosis or like that. Then LFT, KFT, of course, are non-specific. They may only help you in verifying a patient of icteric hepatitis or hepatitis that this patient has jaundice. As Dr. Panda has said, that you may miss hyperthyroidism, which is a common cause of fever. So getting into, of course, clinically, if you're suspecting hyperthyroidism and investigating with the TSH, that may help you free T3 or free T4 along with that. Thyroiditis may again present to you with fever. Coming to the serum ferritin, again, serum ferritin has a great hype in COVID days, and it's an inflammatory marker for undiagnosed fevers where we are not able to localize. Say a patient is having a fever of more than 7 to 10 days and where you have used your usual antibiotics. So that may give you a vital clue that this patient may be having a hemophagocytic syndrome. Special investigations, then you may order. And so keeping in mind these things, that you should plan your investigation. But again, serum ferritin, I'll give you an example. A patient who was having fever and NS1 positive on day 2 or 3 had also a low hemoglobin, say of 11. His physician ordered a serum ferritin just to know whether this patient is having iron deficiency anemia or not. And the ferritin came to be about more than 3,000. Now, this is a very tricky situation, and we as physicians should be very responsible when we are ordering for investigations. They may actually land us in trouble because we do not have an answer. It's an inflammatory marker, but then the relatives will be after you that this investigation has come positive. So this is one message which we like to share. Of course, chronic infections like Shubhalakshmi, tuberculosis, HIV, scab, lepto, brucellola, chlamydia, syphilis, they all have got their specific investigations, and if we are not able to find in routine investigations, then they should be screened for. A basic urine examination should not be missed. Somewhat in a, say, a microhematuria or in the form of a pus cell that may give you a vital clue, or sometimes an asymptomatic bacteriuria or say pyuria. So that also gives you a clue that probably we are suffering, the patient may be suffering from some atypical infection. Similarly, autoimmune profile and screening for malignancy is one thing. Stopping the antibiotics, looking for the other causes may give you a clue that drugs may be responsible for your localizing or your undiagnosed fevers. Then very important investigations, X-ray, CT scans, and MRIs and PET-CT. They have got their own role when you finish off with your routine investigations, but do not switch over to the radiological investigation first and doing the hematological investigations first. Otherwise, it will again lead you into a trouble. Echocardiography sometimes helps when infective endocarditis is suspected. Again, good clinical experience, good level of suspicion is necessary for diagnosing these patients. Then bone marrow and bone marrow biopsy are two investigations which, at least in a tertiary care hospital, we should be coming forward to investigate the patients of fever where we are not able to localize these patients. Again, having said all this, then it is very important to remember, Dr. Shubha, that we should think of common diseases first when we are actually looking for diagnosing a case, rather than looking for the rare diseases. Rare diseases are rarely correct. So that's all from my side.
Thank you very much, sir. So very rightly said and very crisp message that we should go from basics towards the specific investigations, and common diseases should be thought of first, should be investigated first, and then should be going towards the rare diseases, which we can think of in that clinical scenario. moving on to our next question to Dr. Ashutosh sir. Sir, once we are knowing or once we have read that what this definition is and what can be different causes, so what are the treatment options available and do antibiotic have any role in this? We have been talking about this topic.
As we discussed that, for localization of the fever, now, even though we localize in the terms of inflammatory, response, sometimes as that if we localize to suppose the arthritis, as we know, the rheumatoid arthritis or different other to joint inflammation. Now, whether infective, the swelling and the response, all the inflammation like your infection and non-infectious causes. We need to still go further for getting the etiology of infection, like the bacterial infection. So there are several ways we need to really go. We should not jump on. Just if we fail to localize, we should not go for using the antibiotics. Still, we should use our different ways to know clinical and laboratory investigations and imaging techniques. We have that. So to establish the evidence, so the evidence-based practice. So we need to have some clue for using the antibiotic. We cannot use just antibiotic just based on the fever. Thank you.
Thank you, sir. So very clear message that antibiotic is to be used, but not in the first instance. It can be used, but not in the first, that we are not getting the cause of the fever and we jump upon the upon using the antibiotic. That is not at all correct. We should first investigate. We should try to find out the cause as far as possible. Then we should move upon according to the individual scenario. So thank you, sir. Now moving on to our next question with what antibiotic cover atypical infection and what are the causes of non-localizing fever? This is for Dr. Jayant Panda, sir. Would you like to answer this, sir?
Yes. We know there are many atypical infections, as Dr. Agrawal has already noted down. At times, we can get brucellosis. We here in eastern part, we get a lot of cases of scrub typhus. So many people come with a continued fever and even multi-organ failure. And on testing, we get scrub typhus, which responds very well to doxycycline. And when we think of a mycoplasma, maybe a respiratory infection, the macrolides are amazing. And when you think of an anaerobic infection, again, the drugs covering anaerobic infections, they do wonders. And then just we are discussing about the fungal infections. We're thinking of which are not classical, the atypical tuberculosis, the non-mycobacterial infections, and then also the infections which we don't see usually, but if we can locate, it will respond. So here many come under the classification of pyrexia for no reason, and in a non-localizing fever, we have to target them. Once the fever is 2-3 weeks and not worked out, we have to target that, like doing a blood culture to locate the bacterial endocarditis in a patient with the cardiac lesion and echocardiographic finding of the evidence of subacute bacterial endocarditis. Similarly, in a patient who has multiple skin lesions, maybe bone lesions with a deep sinuses and osteomyelitis, not responding for a long time. And then especially in a immunocompromised host like diabetic, we see a lot of foot ulcers, the diabetic foot who don't respond. And many times we have got pseudomonas there. And even recurrent urinary tract infection is troublesome in elderly who have retention of the urine, obstructive uropathy, and especially if they are on drugs like SGLT2 inhibitor, it becomes very chronic and we don't control the infections. So there who don't respond in the first week and come with the complications, we have to target the atypical infections, and depending on the probable clinical site, we have to locate the organism and the the agents accordingly. Then only we can get a clinical success. Of course, the biopsy and the laboratory evaluation of the organism is a must.
Yes, sir. So the cause should be looked after. It should be looked, it should be tried enough. We should get the cause of the infection or cause of the fever, maybe infective or non-infective. And as sir said, atypical infections like brucellosis, scrub, they are very, nowadays it is become very common because we are aware, we are getting it more frequently. So it should be taken care of. So thank you, sir. Now moving to our last question of this panel. It is to Dr. Ramesh Agarwal, sir. So what governs the choice of antibiotic in such situation and in case of non-localizing fever?
Okay, Dr. Shubha, again, now see, this is a double-edged sword. Like as what we have been discussing, like using an antibiotic at first go, should we use or shouldn't we use? And then whether to stop the antibiotic or to further escalate the antibiotic. So this is the whole basically scenario where we have to decide. Now, again, I would like to emphasize that before we start the treatment, we know that we are treating the patient and not looking after. And the second point is that the diagnosis or the actually looking after the disease is the second thing. So the treatment of the patient is a primary responsibility. And especially we have to triage that whether this patient is severely or an acutely ill patient and require and probably is he or that patient is immunocompromised or not? Is that patient having a history of some splenectomy, or is the patient on a hemodialysis? Is the patient on extreme age groups like a pediatric or a geriatric patient? So considering these scenarios, then we should take a decision, and it cannot be a hard fast rule that we are not going to start the treatment for this patient. Of course, we all are sensitive physicians, and this 4 or 5 things that should come as a preliminary thing before we take a decision. Now, having considered these extremes of red flags that the patient may or may not have, then the second thing in a patient where we are not able to localize any signs and symptoms and where we wish to initiate is the presence of hypotension, septicemia, or compromise of the vital functions. A patient comes to us with a compromised vitals with a very low blood pressure and a tachycardia, and you can see that there is a marked leukocytosis with neutrophilia and toxic granules and all that scenario. So instead of just waiting and to localize, there is always an option to go for an antibiotics. Similarly, if a patient comes to say again with confusion and altered sensorium, and you have got very little time to investigate the patient, so an empirical antibiotics can be started. So now coming to the question that once we have decided that yes, this patient needs an antibiotic at first hand. So the question is what actually to cover. So the coverage should include both the gram-positive and the gram-negative bacteria. And from gram-negative bacteria, we can always use fluoroquinones like ciprofloxacin, ceftazidime as per Pseudomonas, the third generation cephalosporins, carbapenems. These are for gram-negative. For gram-positive, we can use vancomycin, daptomycin, linezolid, or quinipristin. So this all we know. So a cocktail of say an initial antibiotics that will probably help the patient to recover, and then of course we can escalate or get down to our initial empirical therapy. The one thing which Dr. Panda has already said that some antibiotics which are for atypical infections like doxy and azithro, say they may be used keeping in your initial suspicion on your clinical examination. Say, for example, in his part of the country, scrub is very common. So there is no harm in adding that to the empirical regimen when you see that the patient is really toxic, or you may find some clinical evidence that this patient may be having from the geographical presence, or say a recent animal bite or recent history to the forest. So these all scenarios may decide in your empirical therapy. So initial judgment will be based on the clinical signs and symptoms, on the extremes of the red flags, which I have mentioned, and a broad spectrum of antibiotics, including both the gram-negative, gram-positive, and coverage of atypical organism will suffice the initial treatment. Yes, ma'am.
Yeah, thank you, sir. So what we are doing, we have to start the antibiotic once we have found out the cause or we are closer to the DD. If not, and patient is sick, we have to go for a broader spectrum antibiotic to cover all. So if we are not having the cause of fever, if we are not able to localize the localize any finding of the fever, we have to try to find out the cause, try to localize the cause of fever. If at all it is not possible, we have to go about with the investigation, that too from the basic to the specific investigations. And then if we are not able to still we are not able to find any cause, we can individualize the treatment. We have to start or not to start the antibiotic. This is very it depends upon the individual condition of the patient, the clinical presentation, the vital signs or the red flag sign. If they are all present, then we have to start the antibiotic in favor of the patient, so that we cannot we are not losing the time in between. So we can go with the antibiotics, that too a broad spectrum antibiotic covering gram positive as well as gram negative. And as sir also told, that atypical coverage with doxycycline can be started if we are suspecting any atypical organism. So thank you all the panelists for covering the topic very nicely. And I think Dr. Anupam Prakash sir is with us. So final remark from him would be great. Sir, if you are there, please give your remarks, sir.
Thank you, Dr. Shubhalakshmi. Although there is no need, everybody has done his and her job very nicely, and you have also moderated very well. And I'm extremely sorry for not being able to join, but I was passing through the security check at the airport, and Dr. Panda is soon to join here. But thank you so much. And I think fever managing is not an easy thing. And 2 days of conference, and this panel has alluded to the thing that we have to keep our horizon wide and try to understand what are the problems that we have, and not only think of infectious diseases, but also think of less common infectious diseases, atypical infections, and also diseases which are not infective, that can also lead to fever presentations. Well, I think that is a wonderful discussion. Dr. Ashutosh, Dr. Panda, Dr. Ramesh, and yourself, thank you so much, and thank you Microlab and PEPCON.
Thank you very much, sir. And thank you all the panelists, Dr. Jayant sir, Dr. Ramesh sir, and Dr. Ashutosh sir. Thank you very much. And thank you, Anupam sir, for your final remarks. Over to you, Manjula ma'am.
Thank you very much.